just get behind what it means to what cost containment is. And so my name is Gray Campbell. I am the moderator here for 6 Degrees Health. And I want to introduce our panel of experts today. We have, I think there's 5 people plus me, making 6 total. We're calling out from, most of us are here in Portland, Oregon, and the Oregon region, but we do have folks from the Intermountain West as well. Scott Ray is our CEO. Scott Ray is joining us via a mobile device because of some connectivity issues with his internet, but he is here. He'll be part of the conversation. We also have Katie Branch. She's our new president. She's been here for a couple months now, and she focuses on the payment integrity side of the business. We have Heath Potter. You'll probably all know Heath Potter. He's the brains behind, hello, Heath, the brains behind this whole this whole series, the Fireside Chat series. So thanks, Heath Potter, Chief Growth Officer. And Bonita Hatchett-Bodel. She's been with us a couple of different times. Welcome, Bonita. Bonita is calling in from Texas. She is our Chief General Counsel, our General Counsel for the company. And then we also have Donald Lee. He is our Vice President of Strategy and Underwriting. Hi, Donald. How are you today?
I'm doing great, Gray. How are you?
Awesome. I'm wonderful. I love your background. Both you and Katie picked a good one. Beautiful background there. And so today we really want to get down into what are high dollar claims and sort of understanding how they can make or break a plan. We were talking about this earlier, Katie, you and me, about how some of these high dollar claims really can force some of our groups into going back to a fully funded model because they get scared of what it means when these big high dollar claims come out. And so I want to bring Scott in. I want to start talking about the selling process, but when it comes to RBP and it comes to what we do, maybe we can just start there with Heath. Heath, tell us about what it means to sell the plan and how, as we're selling in these plans and getting folks set up with RBP, what happens when these high dollar claims start to hit the plan? What's going on here?
Hey, Craig. Well, before we start though,
yep.
Can we clarify? I thought you said Heath's the brains behind this. Was that what I heard?
I had some comments to make about Scott not being on video, which I think is improving this entire broadcast. But
I will just start by saying I have the easiest job in the company as CEO. I just hire people that are better looking than me and smarter. So here you go. We got this crew. Go for it, Heath.
Oh man.
So yeah, just to clarify real quick.
Razzled right out of the gate here.
Scott Ray is our CEO and founder. Scott Ray, I love you. Heath Potter is when we started talking about this Fireside Chat episode or these particular broadcasts about 1.5 years ago, this was Heath's brainchild. Heath really wanted to set up a fireside chat with people in the industry to better understand what happens in the industry. How does self-funding work? What kind of problems pop up? What are the benefits of self-funding? And we've had a lot of great talks about that. And so that's the brain part. Certainly he's the good looking one in the group as well. So Heath, tell us a little bit about selling these plans in.
Sure. I think to start though, for the audience and the folks that have followed us through the Fireside series, which I think goes back to September of October of 20. One thing I didn't want to do was make it a sales tool. I wanted it to be industry knowledge where people could come, feel, like in a safe environment where they can learn without having somebody pitch something to them all the time. And I think we've done a really good job with that. One of the things that we've been asked from the audience is to learn more about 6 Degrees. And so I've been hesitant to do this type of format. And I think we're going to try and keep it as general as possible so that you don't feel like you're getting that pitch. But we are kind of trying something new here. So bear with us and hopefully you learn a few things about high dollar claims, whether you're using us or any of our competitors and how it impacts these plans. So just want to start off by saying that, and we'll see if we can make it through this presentation without Scott and I throwing jabs at each other tomorrow. So I don't think we can do it, but we'll try.
Too late.
All right. So Ray, what did you want me to hit on? Kind of what the from a
Yeah,
sales perspective, or what
I
plans should
just
be
kind of
considering?
want to, for folks who are kind of newer to the industry, like how do we sell in reference-based pricing? And then I do want to kind of get into how cost containment, the sort of like umbrella of cost containment, and recognizing some payment integrity stuff.
Sure.
Yeah.
I think the first thing to understand here is our high dollar cost containment solution is embedded into our RBP product. So if you're using this for reference-based pricing, it's built in there, which I think is a huge advantage for our groups. The unit cost savings, whether you're using our RBP product or somebody else's, is typically going to be delivered just by the nature of a Medicare multiple plan design. But where things can go wrong is on these big claims. And if you look at our data, you can see pretty clearly that our large claim capability shines. And I think that does a couple things, depending on the attachment points for stop loss, or just the plan experience. Those large claims are ultimately the ones that can cause major havoc. So I think that's incredibly important. Now, also, the other half of our business is servicing traditional PPO model plans with a large claim solution. So I think we'll get into that today as well. But whether you're fully insured or self-funded PPO or RBP, these high dollar claims can have an impact on your plan experience.
Yeah, certainly high dollar claims is something I'm learning a lot about. I'm sort of the newbie, the fresh eyes on all this. And we actually picked up a case study, some work that we did on a NICU case that really starts to kind of hammer in about the importance of getting behind containing the high cost of these. Should we jump into that right away, folks? Or Scott, did you want to talk a little bit more about what we do as a company before we do that?
Oh, I guess I could just touch on the payment integrity piece that it's been a point of emphasis for us since late last year. We brought Katie Brandt on as president, who, she's got a long history in building out payment integrity programs, brought on chief medical officer, a number of other clinical resources. And the reason for that is, I think it's important to understand that whether you're paying a claim based on a Medicare multiple or some objective benchmark, or even a contract, whether it's a direct contract with 6 Degrees, or maybe the plan holds it, or even a network contract, there's still, no matter how good that contract is, if there are errors and defects with the claim that you don't pick up before you apply that benchmark or contract, then you're not going to get an optimal result. And so we really wanted to double down on, from the clinical perspective, with respect to high dollar claims. We've always done claim edits on our claims repricing, but when you start getting up into the high dollar claims, we wanted to throw a lot more clinical resources at it, in conjunction with the claim edits, to dial that in. And so it's not only enhancing our reference-based pricing product, but it also allows us to service our channel partners who still have a significant amount of exposure and business in traditional network plans.
How do you define high dollar? Like what does high dollar mean to you, Scott?
Well, Katie can talk to this too. I mean, it's somewhat claim specific. I mean, but I think the key with payment integrity is you don't want to drop that threshold so low that you're just nickel and diming the provider at every turn. You start to lose sight of kind of your return on investment there, and also, if you're picking at them too frequently, that may be counterproductive.
Right. You've got to keep these relationships going. You don't want to badger them too much. Right. Okay. Well, Katie, should we get into the slide and take a look at this particular case study? Let's do that. And so
hey, Gray, before we go too far into that, I want to give a little public announcement here. One of my key responsibilities, which is proven to be a push on my abilities, is to do the Q&A on this. So as you have questions, and I hope you do, use the Q&A toggle or tab or button or whatever you want to call it at the bottom of your Zoom browser screen. You can use chat for whatever, making comments or something, but if you actually have a question, use that Q&A piece, and I'll monitor that and build it into the dialogue here. So.
Thanks, Heath.
Yep.
All right, Katie, what do we got here? We've got a hospital case study something that happened here. And if you start looking at the numbers here, it's a lot of high dollar amounts. And that's kind of a question I had for Scott earlier. And so clearly this could really undermine or could take down a plan in the millions of dollars. Let's talk about it. Let's walk through it and talk about how you impact this case.
Sure. I think Donald and I are actually both going to talk a little bit about this because, as Scott said, there are multiple issues with high dollar claims, and there's really no silver bullet solution that you can provide to cover the costs of these. So at 6 Degrees, our goal in adding clinical bench strength was not just to provide a solution where there's a network in place, but also to provide more comprehensive approaches to different catastrophic claims. And so this is really, a case study to outline some of the important factors that went into this claim and how we approached it from all angles, and we're able to come up with a really great result. So I'll let Donald kind of kick it off here and talk a little bit about the claim summary itself, and then I can dig into the clinical
Perfect.
findings and what we did here.
Okay, thank you.
Hi, everybody. So this was a very interesting case study because, as you can think about it, this is your mid-sized self-funded employer in the middle of the country. And we didn't pick a claim that kind of just went through the motions and just really resulted in those ultimate RVP savings. We actually picked this claim that you can see, and what we're going to talk through hurts everyone in this process because it's a very big claim. There's not a lot of premium dollars tied to this. If you think this group is under 500 lives, self-funded partially in some way, they have some level of stop loss deductible up to $150,000, and they're trying to navigate this. And so claim like this pops up, group renews January 1st, claim like this pops up in November or October, $3.1 million claim. And what happens? Everyone gets nervous very quickly. The stop loss renewal goes to a max increase. Everybody's looking for options. They're not sure what to do. And so there isn't a lot of options. And when you look at those premiums, you got to think about, well, what are we going to be able to do in a long-term situation? Because the traditional approach in this case is to just pay it, let it happen, and let the premiums and loss ratios kind of work themselves on the back end. But if you can get involved, and you should be in your self-funded plan, in the cost containment, the payment integrity, when these things are getting done. So here's the claim, comes in September 30th. So let's say we find out about this claim, $3.1 million in charges. There's a Medicare DRG amount that's under $1 million. And so your Medicare multiple is 333% of Medicare. And a large portion of this has to do with the drugs that were used in an emergency setting to manage this condition. And you get to the charge for these specific drugs is $1.6 million. And so one thing to note on this side is when you're looking at your Medicare multiples, there's things that fall outside of that. And you need to make sure that you have stop loss policies in place that manage these things, that understand that there are certain things like drugs or things that fall outside of the traditional Medicare metrics. And you need to have somebody or a team of people that can look at it from the various areas of the way things cost, community-based, PPO-based, Medicare-based. So that $1.6 million for that one drug, it got sent to us. We started looking at it, and then I'm going to toss this back over to Katie to kind of see what we actually found in the clinical review.
Sure.
Hey, Donald, I just want to touch on one thing that you brought up, which, I think the audience has probably heard us say this before, but it's worth noting that, Medicare is probably one of the best objective payment benchmarks that we have, but it's not perfect. And if you're in this long enough, you'll run into claims where Medicare either grossly underpays or overpays on a particular claim. And I think that it's important for people to remember that, because we have a tendency to just assume that Medicare is always going to be a reasonable benchmark.
Yeah, it's a great call out. And I think, very representative of the number here. What should that have been? It's hard to establish that in these NICU type claims where it's not always applicable. And, certainly for our part, looking at, $1 million allowed amount and the charge for this drug, a clinical review was certainly warranted. And so we requested the itemized bill detail, and we're able to identify actually that the hospital charged for the brand name of a drug that could have been given using a generic with equal effectiveness. So the cost, and we're talking about ASP here, so the cost to the hospital is probably less than that, was about $481,000. Take that down to the generic equally effective drug, it was $5,000. And so what we did was allowed 10,000, so basically a 2 times markup to account for storage and handling, but also with the expectation that the provider is going to use prudence when administering pharmaceuticals. And if there is a generic version, we would expect that to be used and that to be charged. We also found numerous clinical edits, duplicate respiratory support billed on multiple dates of service, over-the-counter medications. This is the terrible $200 Tylenol. But we weren't just talking about Tylenol. It was, Tylenol, Motrin, stool softeners, simple sleep aids, billed at $63,000 on this claim. And we understand that those are at little or no cost to the provider, and they're bought in bulk. And so when you start to look at these individual line items, you could run down to Costco and buy, 100 times the quantity for about half the price. Routine nursing services. So in the inpatient setting, your nurse is part of your room and board charge. That's a standard inclusion in your room. And therefore, routine services, depending on the environment, would not be payable. These are things like starting IVs, doing blood draws, giving blood in the ICU. Those are typical nursing services that should be included in that room and board charge. Pulse oximetry, this is one I think most people have experienced where a small sensor is applied to your finger, or in this case, the baby's foot, and it reads a number on the screen. So they're charging for pulse oximetry monitoring, which is simply placing the probe on the patient and reading the number off the screen. So these were just some examples of what we found in our total review of the clinical components. But again, a great deal of really what we would consider defects or improprieties in the claim, and therefore reduce the total bill charges prior to application of any network discount or any repricing. So the total clinical adjustments on this were just about $2 million, which reduced what we call the appropriately billed charges to $1.1 million.
Yeah, that's amazing. If you take a look at that, it just blows my mind. And something that we were talking about the other day, Katie, too, is, and maybe we want to get into this now, but when you take a look at what self-funded models do coming into the payment integrity piece, what would a PPO do in a situation like this? Like, could you just briefly touch on that?
Yeah, and I think, it's important to note that this clinical review can be applied with RVP or as a standalone in the case of a PPO or a network discount or arrangement. So we get a lot of questions from payers around, what about the BUCAs? What about audit provisions in a contract or prohibitions in a contract? And it's really important to distinguish this as a clean claim review. And clean claim language is usually dictated by state or by contract, and it essentially says that the claim has all of the necessary documentation in order to properly adjudicate, and that it lacks defects and improprieties or errors. And so we're not doing an audit. We're not looking at the medical record. We're not questioning whether or not these services were provided or documented in the medical record, but rather do they make sense built together? And again, in the case of a brand name versus a generic drug, why is the hospital billing in this way when they can use something equally effective at a much lower cost point? So that's really the clean claim review. It is outside of an audit. And I'll tell you, Gray, this is really pretty standard in the industry now. All of the BUCAs are deploying this solution for their fully funded groups. So it's a matter of, self-funded getting a handle on this and really being able to get involved and leverage this type of service, because providers across the country are getting it from all of the BUCAs.
And one thing I did want to kind of bring in is, some of the legal stuff. Bonita and I have been talking before the chat started about, how do we get the plan language set up? How does the legal side of the business help create the plan so that, for example, they don't automatically go to this drug that costs $1.6 million. Bonita, can you talk a little bit about how, here at 6 Degrees Health, we help create plan language for that?
Sure. So one of the things that we do, especially with the use of our RBP product, is to make sure that the plan language permits the use of our solutions. With respect to these drug costs that you just mentioned, that's something we've been discussing internally. With self-funded plans, they're governed by ERISA, which is a federal law that governs employer-sponsored plans. They're required to have certain terms and conditions, in part so that employees know the benefits to which they are entitled, and more importantly, any limitations on those benefits. And so with respect to drugs, I think it is possible to have language crafted and reflected in that plan document that will basically place a limitation on the types of drugs that will be covered under the plan. And the distinction could be, generic drugs, versus those that have a patent.
Right. Well, what else can we talk about with this, Katie? What else do we want to kind of dive into when it comes to this particular hospital case study?
Yeah, and I think, I'm going to have Donald kind of talk a little bit about the negotiations and how we approached this and brought everyone together on this claim. But we did put in here just an estimated PPO discount. So, if this was running through a network of some kind, you're probably going to get a 50% discount. Yeah. And that payable amount would be 1.5 million. And if you look at the appropriately billed charges here at 1.1, it's obviously a gross overpayment, even though a 50% discount might feel kind of good. So we want to make sure that, we're diving into the details on these claims and not assuming that they're billed properly, because a discount off of billing errors is still a billing error.
Yeah.
And we tried to keep this PPO estimate very basic, just a 50% discount. But if you look over there on the left, you can see the facility is actually charging $1.6 million for this drug. And so if you're out there renting a network through a BUCA, you're renting access to those facilities, you're renting access to those doctors, you're not necessarily renting access to what the drugs and how they're being purchased. And so the delta between what you'll find in the PPO world when you're doing this type of work is somewhere between that 1.5 million up to the billed charges when it comes to these specific drugs like this. And then one thing other to call out on top of that, when Katie talks about our payment integrity services that we're able to do on a carve-out basis, when we're looking at claims like this, on average, we are able to do on that upfront clean claim review prior to the audit, see around a 10% savings. And so if you were to send us this claim and it was tied to one of those major carriers, another way to look at it is you got $3 million billed, 10% savings is around $300,000. And so that's a significant amount of money, especially if your stop loss premium annually is somewhere between $200,000 and $500,000. And so this is obviously an RBP case, but you can see the different applications, whether this was a one-off specific PPO-based claim or if it came in through the RBP channels.
And Donald, how does this affect the stop loss relationship? Again, we talked about this a little bit last week, and you had mentioned earlier, hey, this came in September and we've got a full another year popping up around the corner. how would a plan manage their relationship with their stop loss, knowing that these kind of things are showing up at their front door?
Yeah, it's a tough spot to be. I mean, in this case, they're looking at a max increase, and I think that's what self-funding is becoming. If you're managing a plan and you're doing the right things, you're getting in and trying to slow down the process and make sure that you're able to do these sorts of things. So whether you're doing it on plan language or you're doing it some other way with your stop loss, you can kind of manage both those pieces. But it's, in a case like this, it's relational outcomes, partnerships, and long-term success. I mean, like I said, this company, this plan sponsor probably spent less than $500,000 on spec premium. So this is not a great result no matter what. I mean, because they have other claims. And so their loss ratios in a traditional sense are not great. But if the carrier and the plan and everyone understands that how this was managed behind the scenes, then they're able to look beyond that 1-year renewal sometimes, knowing that you're going to get the multiple year success.
There you go. Very cool.
And so jumping over here to the right, I mean, this is kind of where we ended up.
Right.
And it's a bit unique, and it was a bit outside the box, because depending on however your stop loss contract is structured and how the contract is written, there's only certain things that you're able to do. And I think that's where we also are able to help clients navigate that. Between Benita, Katie's team, myself, we're able to get in and have these discussions and slow this process down. Because what we found on the RVP side, the more pure approach to this is when you're able to do all these things, there's not a lot of pushback that a hospital can have. It's like, if you used 1 screw, then why are you charging me for 5? And that auto adjudication that happens on the PPO side really puts everyone in a tough spot. And so on this side, the notes here, I mean, we were able to use the clinical review. We were able to really leverage this far beyond anywhere normally you would have been able to. I mean, this ability to go into the generic drug and have that conversation obviously is a far step from the traditional PPO model. But we were able to leverage those things. We were able to, because think about it, the claim came in September, and now it's going to be, everybody is getting nervous because your stop loss policy is ending. So what they want to do, they want to pay for it. They want to get it paid. They want to shove this through and make it happen. When you do that and you try to get it done within those contract terms, you're going to land somewhere between the $1.5 million down here at the bottom and something higher.
Mm-hmm.
But what we were able to do is actually hold that policy open and say, look, everyone, we need everybody to partner here. And so we need you to leave this policy open so that everyone understands that we're going to pay this claim, but we're going to do it in the right fashion.
Yeah.
So we were able to hold it open 3 months. We were able to talk with the plan sponsor, and because the reinsurer knew how much work was going into this and all this process, they actually waived the stop loss deductible for that company for that upcoming year for this individual, knowing that this care was continuing to be ongoing. And
Sure.
This was just one event in this person's lifetime of care that's going to take place.
Wow. Well, thank you, Donald. That's a great explanation. I always learn about stop loss when we get together, and I appreciate it. I know, folks, we've had some previous fireside chats on that subject, and it's always a good one to dive into. Katie, is there anything else you want to talk about that hospital case study? I do see we have some Q&A questions coming in, and I want to make sure we get to our guests.
No, hopefully this is help kind of exemplify the multi-pronged approach that we're taking to these claims, and how, important that is, and looking at the details, as Donald said, slowing down the process. I know that end of year can be hard for everyone, or just simply trying to get claims paid. And, it doesn't have to be a $3 million claim in order for it to, be appropriate to go through a review. So, I think the question came up earlier, what's the threshold? $100,000 claim can be catastrophic to some groups. So we want to make sure that, we're going into this level of detail and providing these opportunities for more correct payments.
All right, Heath, you got the ball.
Good cue there. So there was a question that came in earlier, and I think Katie, you had answered it during your descriptions here, but we might as well revisit it. It was about, are you able to do payment integrity in and around a BUCA-based plan, and how is it you're able to do that?
Yeah, so I think number one, again, this isn't an audit, it's a clean claim review. And I have never seen a contract that prohibited anyone from looking at the claim for errors, making sure it's accurate prior to billing. And so we want to steer clear of the audit provisions, which are really antiquated contract terms that lock a payer into paying in full and then coming on site after the payment, scheduling it 6 to 8 months out, sitting down next to a nurse and auditor at the provider side and going through the medical record and making sure everything was ordered properly and documented. Well, frankly, providers have spent a long time perfecting their documentation for exactly this reason. That doesn't mean that the way they've charged things on a specific date of service are appropriately billed. So it's a difference between did they get it versus should it have necessarily been included in another charge, or was it a duplicate? Or was it something that's no cost to the provider? Or was it a brand name drug when a generic would have sufficed? So those are the questions we ask in a clean claim review, and that's how we differentiate it from an audit. I can tell you from the last 15 years of working with the BUCAs that they are all using a program like this. So all of their network providers are used to seeing this across the country. And it really is just commonplace. 10 years ago, you're doing a prepayment clean claim review. Hospitals would have been like, what is this? We're up in arms. You can't ask any questions. You can't look at the bill, which, by the way, is crazy. And nowhere else in commerce does that occur where you can't actually look at the bill before you pay it. But regardless, it was somewhat revolutionary, but it's not anymore. It's really become the norm and the expectation. And I think the more payers that are out there enforcing this, we may actually see some positive change in hospital billing practices over time.
Hey, Katie, you made this point earlier, but just to drive it home, because you said, all the BUCAs are doing this, but not necessarily on their ASO business, right?
Yeah, it's a good call out, Scott. So typically the ASO is set up as an opt-in, not an opt-out. And so what that results in oftentimes is not understanding that the program is available through the ASO groups or at an increased ASO rate. So it's a buy up to add in this service. And so it becomes a bit of a barrier for ASO groups to sign up for this type of program, but it's absolutely being deployed on their fully insured book.
Okay. Thank you, Katie. All right. There's a couple others that kind of blend into this. Let's go with there's one, we're going to go in reverse here. How much time does it take to get to that final statement when you start a process like this? Or the settlement, not a statement, excuse me.
Yeah, realistically, this one, I think Donald was probably going to jump in, but it was about 3 months, right, Donald, to get to this final settlement? I'll let you.
Yeah, no, it was right around 3 months. And if you think about any of these, I mean, anybody on here that's ever worked in the fully insured world, and these things, contracts kind of end at the end of the year, 2 to 3 weeks, 2 to 3 months, everybody starts getting nervous in this scenario when they understood that the stop loss policy had been changed over to the new year based on the negotiations and how that was going to take place. It allowed them to open up their ability to say, someone else is actually paying for this claim, and it's not just going to go through the normal process. So, yeah.
I would add maybe one more comment to that, and that is for a standalone clean claim review that is not applied with RBP, so it's applied within a network setting. We're going to turn this review around in about 5 to 7 business days once we have the itemized detail. So it's pretty quick turnaround time, and then the claim is paid according to our findings. We send that information out to the provider and ask that they dispute or appeal directly back to 6 Degrees. But we're not asking for their sign off. And the reason being is if they sign off on this, they're essentially admitting to billing errors and therefore should necessarily change their billing practice. And unfortunately, we haven't seen that, because unless 100% of payers are looking at claims in this way, they're continuing to get paid for these errors. So we don't require sign off. We will definitely honor the appeals timeline and wait for the claim to close naturally, but the savings are realized at the time of payment. And we have a 97% uphold rate, which means very little of the clinical review will be overturned through appeal.
That's some great.
And one more thing to add there on the standard RBP book, because if you're just talking our more traditional RBP basis, we have a median settlement date of around 72 days of all balance bills, regardless. And what that means is essentially 2 billing cycles, because there's always things that are going to come through. There's going to be delays, but that's our median time frame. And within that point, our average balance bill is under $1,000 in our RBP space. And so what does that mean? That means it's not necessarily hitting these types of claims. And so the approach that you take on the smaller claims versus the bigger claims is becoming a very big differentiator. And that's why stop loss carriers are very much getting excited about adding in these programs and kind of taking advantage of what the BUCAs are doing already, but more in the self-funded carve out space.
Okay, thanks guys. We have, okay, so as the question asker, I get the liberty of kind of manipulating these. So I'm going to put this one into 2 parts. The question is, what percentage of savings does 6 Degrees help obtain? And I think this really depends on what products we're talking about here. So if we're doing, traditional reference-based, I think we're averaging around 147% of Medicare, or roughly 67 to 70%. If looking at it from the inverse savings. Now, Donald, you've done a study on all the large claims that we intercept and what that looks like outside of the standard RVP repricing mechanism.
Yeah, it's interesting because it's the inverse of the PPO world. As the claims get bigger and get auto adjudicated in the PPO side, you see them kind of expand. In the RVP side, when we looked at our top 40 large claims, we only had 3 come back as an appeal and only 1 that actually got balance billed. And it's like, why did that happen? And if you think about it, if you do all these pieces along the way and you prove what's been going on, it's pretty hard to fight back. I mean, these are pretty compelling arguments right in front. And so you're able to really slow down that process, have the conversation, and make sure that everyone understands, from the member to the plan sponsor to the broker, and the reinsurer.
And those were closer to 80%.
Yeah, right. And yep. And so, those averaged from a full repricing standpoint out of the gate, which it averaged right around 80%, with the 1 claim that included some significant specialty drugs. We still averaged 76% savings across our top 40 large claims.
That's awesome.
Right. Now, Katie, if we were to look at your average payment integrity claim, I think that story changes slightly, perhaps, in terms of how that's calculated.
It does. So we're finding usually above 10% of the claim has been billed in error. So if you equate that to savings, roughly about 10% of all your inpatient claims are billed in error. I should say 10% of each claim. And we find errors on 100% of the claims that we review. So it's a fairly consistent number, and it's very impactful when you're looking at then applying that PPO discount on top of it. So your PPO discount at 50 essentially becomes a 60% discount. So it's a great complement to those types of network situations, as well as the RBP. But certainly the savings level is different when you're looking at just payment accuracy and claims accuracy.
Okay, I think this one's probably for Katie, but for your non-reference-based clients, can you set this up as a claim feed where you identify potential claims, or is it more on an ad hoc referral basis?
It's both. So longer term, absolutely. We can be prepared to accept electronic data feeds. Actually, normally they're set up to send claims over X dollar amount rather than a massive file with selection criteria. But certainly there can be discussions about it coming either way. And right now we just try to make it as easy as possible. So, if a claim comes across someone's desk tomorrow, they can send it over to us via fax, email, mailman, and we can reach out for the itemized bill if they don't have it and start this review. So, really what our goal is to make this something that can be a la carte, so it can be easily applied whenever it's needed, or it can become a volume play where we do address every claim over a certain dollar amount. So really it's flexible, and we want to help keep it as flexible as possible.
Okay. There was a question way back in the early portions of this broadcast about the name of the drug. Is that something you're willing to reveal?
I'm going to say it wrong, but it's Ammonul. Ammonul. AMMUNOL, Donald?
Something like that.
They didn't ask you to spell it. They just wanted to know what it was, Katie. It's not a test.
Good thing they didn't ask you to spell
Oh,
it.
no, she's not here.
I would have failed miserably. I got lost at the A. Not my strong point. Okay, another question just came in. For health plans, how do you envision 6 Degrees best interfacing with the TPA on high dollar claims? Question 1.
I'll take it. I mean, I think depending on the type of program you're running, if whether it's a captive standalone program, I think the idea is with what 6 Degrees can provide is we can help wrap your plan. We can wrap it with an RBP wrap. We can wrap it with these cost containment solutions so that when a claim comes in the door through your TPA, there's that automatic routing. There's that routing that can be sent directly to our nurses in those scenarios ahead of time versus that adjudication path. And so the more integration that we can get, it's going to be based on the program that each of you are building, whether that's, like I said, that standalone self-funded plan or more of that captive type solution that's sitting out there.
And then part B, Donald, does 6 Degrees step in and take over negotiations and repricing? And I'll let you answer. I'm just the question guy, but it's hard to stay quiet here.
Yes. I mean, yeah, it's interesting. I mean, and this is where we really try to connect the dots. In this case study, for example, this person needed continued care, actual long-term transplant, and we had to continue down a path with that and continue to manage this individual and maintain that service. And so it's very important when you're negotiating and doing all of these things that you're doing it in a collaborative manner and doing it in the right steps in the process so that you're not angering people and putting people in a tough spot down the road.
Okay. And then Katie, if we're just looking at a pure payment integrity view of this claim, kind of give that example in terms of perhaps it doesn't need a repricing or negotiation.
Yeah, I think, number one, I guess connection with the TPA and that communication. So obviously that's the point where we want to get these claims. Once it reaches the stop loss carrier, it's oftentimes already been paid. So in looking at slowing down the process just a little bit, that's really the best attachment point prior to payment of the claim. In terms of, negotiation, again, our goal is really to uphold these findings as clinically sound and reference-based, meaning that the CMS regulations, the UV editor guidelines all support this type of review. So we're not identifying savings and efforts for standalone payment integrity to settle at somewhere in the middle. We really intend to work with the providers, help them understand the review and the error of their ways, so to speak, and the guidelines that support it. So that's really how we have such a high uphold rate. It's not about negotiation. It's about defense of the findings and the review legitimacy. And we find that to be really important because, we're going to be nationwide, just like all the other payment integrity providers. And we don't want to back down from things that we know are appropriate adjustments or in fact billing errors.
Hey, can I add one thing to this? I think it's easy to get a little bit confused as an audience member because we're kind of switching back and forth between talking about a reference-based pricing product and a payment integrity solution on a network-based plan. And so I think it's important to keep those two contexts different or separated because like in a reference-based pricing plan, when there's a balance bill or a dispute from the provider and there is let's say there's an additional payment made from the plan to settle a case, those almost always come with sign off. right? Because you're making an additional payment to that provider, and we would always recommend that there is a sign off there. Of course, we can't, if a plan decides to make a payment without getting sign off, we can't control that. But from our perspective, it would always come with sign off. But then distinguish that from what Katie's talking about in a network-based plan, then like she said, it's not a negotiation, it's defense of our findings. And so there isn't necessarily a sign off that comes into play. There's an underlying contract that exists there. And I think one of the things that Katie has done a great job at is, I think there's a lot of folks out there that can identify errors and problems with claims, and not to diminish the expertise that it takes to do that. But it's also, I think, a really critical part of the success of this program is having really solid support on the back end, so that when there is an appeal, that you have high quality people that can uphold, like she said, that really high uphold rate, 97%.
Okay. I had happy fingers and said I answered one, but I didn't. So I'm going back and rereading this. This is an RBP based question, Donald. So I'm going to throw it into your campfire there. When you complete these reviews, do you reduce, I'm guessing this means claim, CLM, claim after the RBP pricing with the bill review results? One. Then two, do you use this to negotiate? If you negotiate on some and it's over the RBP threshold, do the carriers cover it?
There's a lot in there.
A lot.
Yes, yeah. Yes, and maybe is the answers. So yes, we take that off the top. That's kind of the point. You remove that so you clean the claim. But when you get to the far end of that and the stop loss carrier, that's going to come down to the contract and the way that it's been put into place and how you're able to be flexible within those terms. And so A, on the front, we would reduce the claim, and B, we would use those for negotiation. But C, it's going to be on the backside and that discussion you're having with the stop loss carrier. Because if you remember, the plan is paying for it, and then the plan is going to their reinsurer to ask for reimbursement for the claim based on the terms of the plan document.
Not in the question, but Donald, do you get involved with these types of claims and helping our clients?
Yeah, that's what it's, yeah. I mean, like we talked from the beginning, in the beginning, it's easy to show 70% savings on an RBP plan. On the backside, when you have a $3 million claim on a $500,000 stop loss premium, you got a different way to do that. And so, yeah, that's part of my team's role. And they're kind of in from the beginning of the process to the end of the process, because they're going to be the group that's providing you with that initial savings analysis to see what your current program looks like. And then they're also going to be on the backside helping navigate these types of discussions.
So this next question, I think this probably goes back to Scott's statement that we're kind of have two parallel discussions going here, because our reference-based plans do get the benefit of our cost containment and payment integrity solution. And maybe the question came in before Scott had mentioned this, but on the RBP side, we do seek sign off on those, if it was a balance bill situation or seeking a different reimbursement. So let's put this towards Katie then, payment integrity. There was a mention that there's not sign off from the provider. You want to explain why that oftentimes isn't necessary under a pure payment integrity claim review?
Sorry, help if I was off mute. Yeah, so, I think I mentioned that, it's important, number one, to verify the billing accuracy on the claim. And it's important to engage in that dialogue with the provider so they understand why things were removed from their claim and what the foundational regulations and support are for that. However, if they can't demonstrate that an item is payable, by some sort of documentation, billing policy, even potentially some medical records, although not often, then it is where it is. So the onus is on the provider to show why something should be payable. Why should the payer have to reimburse for the brand name drug when an equally effective generic form is available? And so sign off isn't really required for that reason. But additionally, I think I said that, signing off on this type of review would be saying, yes, we admit that these are billing errors, and we would require that they change their billing practice. And it's especially important if they take Medicare and Medicaid, because if they've admitted they have billing errors in their methodology and they continue to bill that way, well, that becomes fraud. So we're not expecting them to sign off on this for that reason, because really not every payer is looking at claims in this way. So they're still continuing to get paid.
Gray, I'll kick it back to you. My Q&A panel
Got through them.
Is run dry. Yeah.
Well, folks, I really hope that everybody enjoyed this as much as I did. Again, I'm fairly new to the industry. I've been around for about a year and a half. And I've learned so much about how health insurance works. And certainly as we grow as a business, we are starting to take on new and more sort of like comprehensive responsibilities across the board in this industry. Bringing on Katie Brandt with her knowledge of payment integrity has been just eye-opening for all of us here at the company, but certainly for our clients and our members as well. And so we're so proud to have you, Katie. Thank you so much for joining us today. And obviously Heath and Bonita as well. Heath, always a pleasure to have you around. And Bonita, would love to get into some more of the legal speak on some future episodes. Donald, maybe a possibility of getting some more stop loss topics down the road. I know we've had like Scotty Campbell here in the past, and there's been some fun conversation about stop loss and plans and how that all works together. Scott Ray, I know we couldn't see your pretty face, but we enjoyed your commentary. Thank you very much, Scott. And honestly, just really stoked to be a part of this company and this industry. I feel like 6 Degrees Health is really making inroads at keeping costs down, being transparent about the information. I think Katie talked a lot about that today. Excuse me, allergies. Must be this lake behind me. Katie talks a lot about holding these providers accountable to their charges. And I know we're not trying to pick battles necessarily, but sometimes we have to, right? And so thanks, Katie, for explaining that process. I learned a lot about that today. Does anybody here on the panel want to have any final thoughts before we close out today?
Well, thanks everyone for attending. This has been a great conversation.
Awesome. Folks, thank you so much for attending. We do this once a month. The idea behind these, and Heath explained this earlier, is to talk about the industry, talk about the self-funded industry, talk about healthcare in general, topics that come up. You're always welcome to suggest some ideas if you have them. Follow us at 6degreeshealth.com. You can go to our webinars. You can watch old webinars, check those out. We're going to be sending out an email thank you at the end. Feel free to reply to that email if you have some ideas or some guests that you want to see involved. I'd love to hear your ideas. We're also all on LinkedIn. Feel free to connect with us on LinkedIn in order to push those ideas around as well. Heath Potter, anything else to add?
No, just great job, everybody. I get to sit back and watch the fun unfold, and it was nice to have everybody on the call today. It's kind of had a nice feel to it. I know that Bonita didn't get not a lot of questions for legal today. So I don't know if she had anything she wanted to wrap up with here at all, but she's also running a CE program for credit free, offered by 6 Degrees. So you can pick that up on our website as well and get registered. And she's got a monthly course that she's doing there. So.
All right. Yeah. Thank you. Please join us. We'd love to have you.
Folks, thanks, and take care. Enjoy the springtime. Get out there for St. Patrick's Day. Have a beer on us, and we will see you next month for our next Fireside Chat. Thank you so much.
Thank you.
Thanks, everybody.
Bye-bye.